Yeah. Oh, you're all sitting together. Yeah. There's so much.
All right, welcome everybody. We're going to get started with today's CPC. It is my pleasure to be joined by Dr. Nicolo Cabrera from Infectious Disease today to discuss the case of a 54-year-old male with a history of diabetes, hypertension, atrial fibrillation, chronic kidney disease, and recently diagnosed sarcoidosis with renal and bone involvement, who is presenting with weakness, dyspnea, and rash. We have no disclosures today. And as always, we like to take the first few minutes to get to know our expert and hear your thoughts on our one-liner. So take it away, Dr. Cabrera. Get back to the case. First, I'm going to start with the recent medical history that resulted in a diagnosis of sarcoidosis. So about 4 months ago, on routine blood work, he was noted to have worsening renal function, thought to be AKI on existing CKD. He went to an outside hospital where his labs were notable for hypercalcemia and paraproteinemia. So his AKI was attributed at that time to be due to hypercalcemia. And there was some concern for a monoclonal gammopathy of renal significance or possible multiple myeloma. So he was referred to nephrology and hematology oncology. He saw both nephrology and hemonc, and there was the concern for multiple myeloma persisted. So he then underwent about 1 month ago a bone marrow biopsy. That ultimately was negative for plasma cell neoplasm, and as you mentioned, did show non-necrotizing granulomas, and the AFB and GMS stains were negative. So this brought up a possible concern for sarcoidosis, and he underwent further workup at that time. He then had a renal biopsy that showed chronic interstitial nephritis, which could be consistent with sarcoidosis. He underwent a PET scan that showed FDG-avid lesions in the bone, bone marrow, supraclavicular, mediastinal, and abdominal lymph nodes. He had a 125 vitamin D and ACE level that were markedly high. And so this was all raising concern for underlying sarcoidosis, but he did have some infectious workup, as you mentioned, before this diagnosis was made. And he had a histoantibody, which was negative, a blastoantibody that was negative, and a T-spot that was negative. So at this point, he was started on prednisone 60 milligrams for sarcoidosis. So now I'm going to walk you through his current presentation. 2 weeks ago, he reports that he started to feel generally very fatigued, general weakness, and noted a diffuse rash. About 1 week ago, he developed headaches, myalgias, cough, dyspnea, a burning sensation in his eyes. He didn't have any overt fever at home, but he did measure a temperature of 99.9. 2 days ago, he presents to an outside hospital because he feels his weakness has progressed to the point where he's having falls. They did a CT head at the outside hospital that was normal. They did some x-rays to rule out any fractures as a result of the falls, and that was normal, so he was discharged home. 1 day ago, he presented back to the outside hospital because his blood sugars at home have been really elevated in the 500s. They were going to admit him there, but he wanted to be treated here at Barnes-Jewish, so he left AMA and is now presenting to Barnes. He's coming in today saying that his weakness has progressed, mostly in his lower extremities, but he also feels generally weak in his upper extremities, and it's to the point where he is having difficulty ambulating. And he's also noting that this blurry vision is ongoing and this burning sensation in his eyes is very troublesome. Any additional comments from these details?
So my initial impression that there could be an infectious process at work that could explain the initial presentation. What calls that into question is monoclonal gammopathy, for example. So we do see paraproteinemias and gammopathies in many infectious processes. So that's practically textbook for Hep C, for HIV, where you have dysregulated immune response, and so they're making so many antibodies. And if you were to modify, for example, the reticuloendothelial system and you were to overstimulate that, then I'm not surprised if you would have a polyclonal gammopathy there as well. So for example, from a fungal or mycobacterial process, although honestly, I'm not sure if that's particularly well described. But to say that this gammopathy is monoclonal, that makes me suspect that there is a hematologic process at work. Maybe if this was not a plasma cell disorder, maybe there's an undiagnosed lymphoma. So I'm having trouble shoehorning that to my initial map in my head. Oh, this is all going to fit together. That's one. A lot of the symptoms that's described could be very nonspecific for a acute viral infection. And it may or may not fit with everything that has come so far in my prior theories, but I do think we obviously need to investigate two things more closely. One is this lower extremity more than upper extremity weakness, and I'd like to see if there's a structural lesion that I can fit into the rest of my differential. And second is blurry vision and pain in the eyes. That's a little bit of an unusual, I wouldn't say impossible symptom, but an unusual symptom to fit into some generic acute illness. So, and again, I always have to look this up if it's episcleritis or scleritis that's painful. One of those is painful and the other is painless. Uveitis is typically not painful, although I guess you're going to find exceptions there. But also, I'm also interested in whether is there actually an intraorbital mass lesion that also explains the pain, and it's not the eye itself. So very vague thoughts, sorry.
Great. So a little bit more details about his past medical history. Outside of this new diagnosis of sarcoid, he just had gout, diabetes, hypertension, and AFib. Surgical history only notable for these recent biopsies. Family history notable for some cardiac disease. No known drug allergies. His medications are listed on the right. I'll specifically point out that he is still taking prednisone 60 milligrams over the last 3 to 4 weeks, and he has been taking Bactrim double strength 3 times weekly for prophylaxis since starting the prednisone. His social history is notable for being a never smoker, social alcohol use, he's never injected drugs, and occupation-wise, he works a desk job at a printing company, and he lives in suburban Illinois and has not had any recent travel outside of the Midwest.
Oh, sorry, I should have asked this in the earlier interlude. The bone marrow was, when it was biopsied, they only looked at path, correct? And they didn't send it for culture. And they sent blasto and histose serology, but did they send antigen as well?
Serologies is what I saw, yeah.
All right, thank you.
All right, so review of systems for this patient. Constitutionally, he's reporting malaise and fatigue, no overt fevers, chills, weight loss, weight gain, or night sweats. For his HTN systems, he reports this headache, blurry vision, burning sensation in his eyes, and under eye swelling that is most notable to his family. No ear symptoms, no sore throat, and he also notes an ulcer on his tongue. Pulmonary-wise, he's had this dyspnea on exertion and cough, but no sputum production or hemoptysis. Cardiovascularly, reports swelling of his hands and feet, but no chest pain or palpitations. No GI or GU symptoms. MSK-wise, he's just got kind of diffuse myalgias, and then he also notes bilateral knee swelling. For skin review systems, he reports a diffuse rash with no itching. And then neurologically, he reports just sensation of diffuse weakness, again, lower extremities a little bit more than upper extremities, and then the headaches, no seizures, tremors, numbness, tingling. Any additional thoughts based on the review systems?
One other thing that I probably should have already mentioned earlier, I did not include hyaline molds very high on my differentials, and this is totally the wrong direction for rhinocerebral mucormycosis to progress, like from somewhere else and then there. But here you have a patient who has something going on in the eye complex, in the mouth, there's an ulcer, and then you have him with a history of uncontrolled diabetes. I think definitely that's something that should be urgently evaluated. Take a look at the sinuses, especially if ENT could take a look at them, and maybe follow that up with, if I didn't think that we needed orbital imaging before, then I think we definitely need that now. I also noticed that you have, so ENT will take a look at that, reevaluate whether we should be worried about mucormycosis, because that's very, very urgently actionable. Since they're there, there's an ulcer on the tongue that they can biopsy as well. And then you mentioned bilateral knee effusions, bilateral knee swelling, and if there are effusions, it would be a good idea to tap those.
Great. All right, so we'll jump into the physical exam and see if there's any effusions to tap. So vitals-wise, his blood pressure is a little low, 90s over 60s. He's tachycardic in the low 100s, satting 95% on room air, and afebrile. Generally, he's ill-appearing. His HENT exam is notable for conjunctival injection, more so of the left eye, generalized facial swelling, most notable under his eyes, and then an erosion with jagged edges on the right lateral tongue and petechiae on the hard palate. No palpable lymphadenopathy was noted, and his neck was noted to be supple. Cardiovascularly, he was tachycardic and irregular. Pulmonary-wise, his lungs were clear. Abdominally, he had some mild diffuse tenderness, but no rebound or guarding. His skin exam was notable for a diffuse purpuric macular rash, mostly on the lower extremities, but also involving the upper extremities. This rash spared the palms, soles, and buttocks. His MSK exam was notable for bilateral lower extremity edema and then swelling and erythema with likely effusions of the bilateral knee joints. His neuro exam, while he was reporting generalized weakness, there was no motor weakness reproducible on his exam, no cranial nerve deficits, and he was alert and oriented and mentating well. All right. Any comments before we progress?
Definitely needs an eye exam and ENT exam. And I'd be very interested to see what those macules actually look like.
Okay. Unfortunately, there were no photos taken, so I don't know, but this is the best description I could give. Okay, we'll get some of those studies done shortly, but first I'm gonna start with just his initial labs. So we've got his chemistry, CBC, and coags. His creatinine was elevated at about 3.6, which is close to where his labs have run recently. His BUN was 60. His bicarb was newly low at 18. Sodium was slightly low at 130. Potassium was elevated at 5.4. At this point, his calcium had normalized. And then for his liver function test, he had low protein and low albumin, but his AST, ALT, and alk phos were all normal. CBC notable for stable anemia. His hemoglobin was slightly low at 11, and then new thrombocytopenia with platelets of 100, and you can see his diff below. And then he did have an elevated lactate on presentation to our emergency room at 3.5.
Well, so hyponatremia, we think of things like legionellosis, but that's a little bit difficult to shoehorn into this diagnosis. I don't know, so the myalgia's fit, overall being very sick, hyponatremia, but I'm not sure how that would produce like a lot of process that's making the face swell up, the eyes swell up. That doesn't fit very well. There's thrombocytopenia, which might still go along with a potential reticuloendothelial process with invasion there, but that could be very nonspecific as well. In a very sick patient, there is some degree of thrombocytopenia. I would note that the liver enzymes, the hepatocellular enzymes are pretty normal. The bili is pretty normal. Makes me think less of something like a tick-borne illness like Rocky Mountain spotted fever or ehrlichiosis or something like that. So none of the information so far like pulls me toward or away from a particular diagnosis that I had mapped out initially.
Okay. So we're next going to go into your management and workup. You mentioned wanting an eye exam, tapping the joints. You wanted some CT head and CT orbits as well, and ENT.
Yes.
What else?
And I'd also be interested in the lungs to see if there are any lung lesions that could explain the degree of, actually I don't know how was he hypoxic?
He was not hypoxic.
But he was short of breath.
Yes.
So I would like to see that.
Okay. All right. So I'm first going to start with the imaging. We did get CT head that was completely normal. They actually did not pursue a CT orbit.
At all, okay.
So next I'd like to invite Dr. Kai Kendall from Radiology Cardiothoracic Imaging up to discuss his initial chest imaging.
Hi, thanks for having me. I was excited about this case because I actually read it in the ED as a fellow last year, so it's familiar. So here on chest radiograph, we have an enlarged right hilar mass as well as multiple consolidations throughout the lungs. You can see in the left upper lobe, there's this nodule, as well as just smaller nodules throughout the entirety of the right lung as well. Not sure, do you usually do we just describe the findings?
Yeah, you can describe.
Okay, and we recommended a CT at this point. In the CT, you have better visualization of what we saw in the chest radiograph. There's these small nodules predominantly in the upper lobes in a tree and bud distribution. And additionally, there's larger nodules, some which have central cavitation in both upper lobes as well as the right lower lobe. There's also trace right effusion. On soft tissue windows, we have enlarged mediastinal lymph nodes as well as a right hilar lymph node. So in summary, on the CT, we have upper lobe predominant pulmonary nodules in a tree and bud distribution, as well as larger pulmonary nodules with central cavitation and mediastinal lymphadenopathy. We did have that prior PET CT before he started steroids, and we can see that there are a few pulmonary nodules present, but the majority of this is new and increasing, as well as the size of the mediastinal lymph nodes are increasing as well.
So, is this where I?
Thank you.
Okay. So there's a lot of tree and bud that suggests something endobronchial, but that's not really the money shot here, right? Because that could represent a wide variety of pulmonary diseases, some very benign, indolent, like for example, NTM. That's not what this is. This patient is very, very sick. So the money shot is with the, to some degree, the hilar lymphadenopathy pushes us towards there, but most importantly are these mass-like consolidation, round nodules and consolidations, and particularly the one in the left lung, and correct me if I'm wrong, maybe I'm just imagining this, is that a reverse halo sign or evolving into a reverse halo sign that we classically associate with mucormycosis, but that could be true for any of the endemic mycoses. I don't know what to make of how peripheral they are. They're very peripheral. They're very peripheral. I don't know if that's supposed to have clued me into a particular etiology, but right now my money is on endemic mycoses, and because you didn't really set me up with significant TB exposure, I'm a little bit less worried about TB right now. I guess among the fungi, it could also be something like Cryptococcus, but I suppose it's possible with steroid exposure, but for this patient to have come in for their entire presentation, even before steroids had been given to this patient, it seems a little unusual for a relatively immunocompetent person to have had Cryptococcus all the way from the very start, but like I've been told, things are changing.
Thank you very much. Okay, so we're going to, you mentioned concern for endemic mycoses, fungal infections.
I was going to ask for a serum cryptoantigen, but I don't know, serum cryptoantigen, urine histoantigen, serum galactomannan, but I don't know if you'd like to save that.
Yeah, absolutely. I was going to ask you what you wanted to order. So it sounds like some of the serologic studies, serum cryptoantigen, anything else?
And then any travel to the southwest of the United States, live there, even a layover, nothing like that, nothing at all, just lived around this area.
I don't think so.
No, because that's not something you travel with. So for example, there have been cases, and of course it's always easy to collect history in retrospect, but there are patients who develop pretty serious coccidioidomycosis, and their only exposure was a layover in Arizona. Maybe it was because they were extremely unlucky and there was a big gust of wind that blew in a lot of dust. And I know social history is very difficult and exposure history is very difficult. I recently had a resident who asked me, oh, I wasn't able to get that history because I wasn't interested in anything that happened beyond the last year. So how do you know how far to dig back? And I said, well, that's why we go into ID fellowship. But the answer, that's a little facetious, but the answer is it depends on what you're asking about. If you're asking about typhoid, I don't care if they were in India last year. But if you're asking about a potential exposure to coccidioidomycosis, then their entire life is on the table, right? Their entire life is on the table for TB. Their entire life is on the table even for let's say, maybe they had a history of Kadayama fever when they were a kid, and now they actually have schistosomiasis now. So the length and duration of interest, or how nosy you are and how far back you dig, depends on what kind of history you're getting, and that depends on what patient you're faced with.
So I'm not aware of any layovers in Arizona, but that being said, Coxi antibody was sent.
Okay.
So we will jump into the initial infectious workup, and I'm going to give you the workup sort of in real time as they would result during the hospitalization. So initial infectious evaluation included an HIV test, which was non-reactive, an RPR, which was negative, a respiratory pathogen panel, which was completely negative, and then 2 sets of blood cultures are cooking. Due to concern for a possible fungal infection, there was filamentous fungal cultures also sent, and those are pending. And then a lot of the studies that you mentioned, histoantibody, histourine antigen, blastoantibody, Coxi antibody, Aspergillus galactomannan, T-spot, were all sent. The serum cryptococcal antigen never was collected, but it was ordered. All of these are pending. And then you mentioned going after other samples. So you talked about the ulceration on the tongue. So dermatology was actually consulted and they decided to biopsy the rash. They went for the rash on the foot. And the prelim data from the biopsy that's coming back right away is that there were no PMN seen and the gram stain is negative, and they did send off a culture from that skin biopsy, and that's also pending at this time.
Oh, sorry, did you?
Yeah, you can go ahead.
It's a good time. So just not dispositive, but some comments. So this is not the patient for whom an Aspergillus. If Aspergillus galactomana were positive, I would be surprised. The best performance of Aspergillus galactomana in patients with hematologic malignancies who have neutropenia. So when we send them and they are negative, they do not convince us that there is no invasive fungal disease in a patient, let's say, with a solid organ transplant, or in a patient like this, who is not neutropenic. So it might be helpful if it's positive, but it's less helpful if it's negative. Urine histoantigen. It might be helpful if it's positive, but an immunocompetent person might be handling their urine, their histoplasma well enough that you don't find urine histoplasma antigen, even if they have relatively serious disease. Although for this patient, it's pretty disseminated, so if they have disseminated histoplasmosis, it's probably going to be positive, but I'm just saying it depends on how widespread the disease is, and immunocompetent people might not have positive urine histoantigens. T-spots, I mean, so a T-spot is not dispositive. Sure, we send it in these cases, but just to give you an idea of how terrible these tests are, I'm PPD positive. I got treated for latent TB. I'm IGRA negative, even if they tell you that you're supposed to be IGRA positive your entire life. That the agreement between these different TB exposure tests is not very strong. And their ability to capture every single patient who has been exposed to TB is not great. And to make matters worse, if you look at cases, cohorts of patients who have florid TB, maybe up to a third to a quarter of them will have negative T-spots and IGRAs. And that sort of makes sense, because it's the patients who cannot mount an immunologic response who are more likely to develop reactivation disease. And what you're actually seeing in a patient who has TB with a negative T-spot is that, yeah, this person was going to get TB. So it's not dispositive. So sure, send them, but never allow yourself to be lulled into a false sense of complacency with respect to that test. And I'm glad that Durham biopsied the foot, but I still want a biopsy of the tongue, and I still want a biopsy of that peripheral lung nodule or lung mass, if it's possible. And I know that a lot of services say that ID is so high maintenance and we keep asking for stuff. And that's true, we do keep asking for stuff. And sometimes maybe it's unreasonable, maybe we ask for too many echoes. But tissue, for a lot of these differentials and for a lot of these diagnoses, is very important, because sometimes you don't know which cut will capture those two tiny TB tubercles, right? Our job is hard because our diagnostics are not perfect. And that's why we keep on asking for stuff.
All right, so we are going to get a lot of samples for you. Unfortunately, the tongue was never biopsied, so I will not have that for you. But I'm going to give you a little bit of an update of how he's doing when he's admitted. So he's admitted to the medicine floor. He started on Vanc, Cefi, and micafungin. On day 2 of hospitalization, he has facial swelling worsening, voice hoarseness, and stridor. So this is when you get your ENT exam. They come in, they didn't have any concerns about his sinuses, but he was noted to have swelling of the pharynx, epiglottis, area epiglottic folds, vocal cords, but his subglottis was patent. He was started on dexamethasone, transferred to the ICU for airway watch, and unfortunately his exam worsened quickly and he was intubated on arrival to the ICU. So my question for you is, at this point, if you were an ID consultant called this day, you know, this guy's clinically worsening, ending up intubated in the ICU, would you be changing your recommendations for antimicrobials?
Oh, yeah. Sorry, this patient should have been put on micafungin. This patient should have been on ambisome as soon as we had seen those that CT scan. But with respect to, I don't want to look in this direction because that's cheating. They might give me an idea, but nothing. Unfortunately, to my misfortune, the swelling of the pharynx, epiglottis, epiglottic folds, it doesn't ring a specific bell to me. And maybe I will learn something today that this represents something related to a specific ID disease that I didn't know, and that would be cool. But it doesn't ring a bell to me.
And I think in the end, his airway edema was attributed to sort of total body volume overload and was not necessarily part of a syndrome. Okay, so next, now that the patient is intubated, you talked about trying to get lots of samples for infectious workup. Now that he's intubated, what would you want to do to acquire samples?
So wonderful, he's intubated, so he's not in the too sick to bronch dilemma. So I would love to get respiratory specimens to send for AFB and fungal cultures.
Okay.
And then well, I guess you could still send a trach aspirate for galactomannan. Those are my ideas.
We can
right now.
start there.
Yeah.
All right. So I'm going to run through a bunch of workup that was done next. So as you mentioned, now that his airway was secured, he had a bronch with
So these
BAL.
are all going to turn positive, are they? That's why they're pending.
Well, I'm trying to give them to you in
Okay.
real time.
In
They
real
don't
time.
result
Yeah, yeah, yeah.
immediately. So the pneumonia PCR was negative, TB PCR off the BAL was negative, and then they did send bacterial, fungal, and AFB cultures, and those are pending. I will give you some of the infectious workup that is now resulting on day 2 of the
So
hospitalization.
just so I can map it out in my mind, what you're teasing me with but not giving me is a routine blood culture, a fungal filamentous blood culture, and then respiratory cultures, right?
And the foot biopsy culture.
And the fit biopsy culture.
So some of this is going to result now. So blood cultures are no growth to date at 48 hours. Filamentous fungal culture also no growth to date at 48 hours. His T-spot is now coming back negative, blastomyces antibody negative, cocci antibody negative, galactomannan negative. Histourine antigen is positive at 8.9.
That's so
Histo
positive.
antibody positive at 1 to 16. Any thoughts on the histo studies?
I mean, that's pretty darn positive. That's pretty darn positive. But we also need to remember that urine histoantigen has some cross-reactivity, but luckily its cross-reactivity are with things like blasto, where the choice of treatment lie along the same lines.
And he was started on ambisome on arrival to the ICU, so he is now on amphotericin. Okay, you wanted an eye exam. So ophtho came in at this point. They did a dilated eye exam. They noted some diabetic eye disease, and then they did note granulomatous lesions in the macula that could be consistent with ocular sarcoid or a fungal infection. So at this point, they also go after the knee effusions. This is where the drumstick comes in, everybody. So they did bilateral knee aspirations. The fluid was turbid. There were about 4,900 RBCs. The left knee had 35,000 nucleated cells. The right knee had greater than 50,000. This was about 70% neutrophils in both samples. The gram stain was negative. No PMNs were seen. And bacterial and fungal cultures were sent, and those are still pending. Okay. So at this point, I'm going to give you another clinical update of how he's doing. So he remains critically ill in the ICU, intubated. He develops distributive shock requiring vasopressors, and due to his renal failure, he started on dialysis. So we're now just 1 day later, day 3 of hospitalization, and now some of your data that is pending is starting to result.
Before that.
All right, so blood cultures result, 2 out of 2 bottles show encapsulated yeast growing at 50 in one bottle and 65 hours in the other. What do you make of this?
Is this crypto?
That's definitely what the thought was at this time. And I'll show you some more data. So now the skin biopsy of the left foot comes back, consistent with cutaneous fungal infection and numerous yeasts seen in the dermis that are morphologically compatible with Cryptococcus.
Are you now going to tell me he sleeps with his chickens, like in retrospect?
I don't know about any chickens. Okay, so shortly after all of these are coming back, all of your infectious data results, the blood cultures speciate with Cryptococcus neoformans. The fungal cultures also grow Cryptococcus. The skin biopsy culture grows Cryptococcus, and they did resend the serum cryptococcal antigen, and that was positive at 1 to 80. A couple days later, the knee aspirations grow Cryptococcus. The BAL grows Cryptococcus, but also blastomyces species. And then the AFB samples sent off the BAL also grow moderate Mycobacterium avium.
That's annoying. No, that's annoying because the choice of azole, so I mean, now while he's on ambisome, that's great. Doesn't matter so much. But looking forward into the future and what the azole of choice would be, because an azole of choice for Cryptococcus, we typically would use fluconazole, and for blastomyces, we would typically use itraconazole. So we'd probably use something else. Anyway, and then the MAC. Have we sampled his respiratory tract multiple times?
That was exactly the concern from the ID consult team. So he actually had multiple BALs,
So
and
the
it
issue
grows
is-
off of 3 of them.
Oh, God. So this is the problem. So remember, back, we took a look at the CT scan, and I said, oh, look, there's a lot of tree and bud actually, but that's super non-specific. The money shot is these nodules. Now I have to think about that again, like maybe it is related to a true MAC infection. Like,
Yeah, so they felt like after the 3rd sample grew mycobacterium that it was a true infection. They
I'm
ended
glad
up
I'm not
treating
following
it.
this patient in the clinic. Like,
So the diagnosis at this point is no secret. It was disseminated cryptococcus, but the case isn't completely over. I want to ask you, what next? You have a patient who is on steroids, presenting with cryptococcus growing out of pretty much every specimen that was collected here. Is there any other part of the body that needs to be sampled for this patient?
so yeah, well, you were leading me up to this. So he needs an LP because we need to rule out meningitis, and then and then my other thought was. So we have to ask ourselves, did this patient have cryptococcal disease from start to finish? Or did the patient have sarcoidosis and then the steroids allowed him to acquire cryptococcal disease, blastomyces, and MAC? So my question is, what is the length of time between the time that this patient got started in high-dose steroids and the time the patient presented with all of this?
2 to 3 weeks was the
That's wild.
steroids was started about 4 weeks ago, and he first started reporting symptoms about 2 weeks ago.
That's wild.
Yeah.
Like, so I mean, that's wild if the patient had sarcoid and the patient acquired all of these opportunistic infections in the 2 to 3 time period, which means do any of these diseases, are they responsible for what had been going on from the very beginning? And some of the things don't fit. So for example, the eye. You typically don't see frank histoplasmosis of the eye. There is an entity called presumed ocular histoplasmosis syndrome that's so hand-wavy and I don't completely understand. So, yeah, I don't know.
Yeah, I think the teams involved in the care of this patient had the same question. Was there an underlying infection that preceded the diagnosis of sarcoid, or was this due to immunosuppression for the treatment of a true sarcoid condition? And I'm not sure the answer, honestly. For the sake of time, I'm going to jump through all of the remaining studies here.
Yeah.
So as you mentioned, they needed to rule out cryptococcus meningitis. So he had a lumbar puncture, showed an elevated opening pressure of 35. It was cloudy, low glucose, elevated protein, RBCs 40, nucleated cells around 3,000. The CSF cryptococcal antigen was markedly positive, and of course the CSF cultures also grew cryptococcus. So how did this patient do? He developed significant neuromuscular weakness during the hospitalization. They actually consulted neuro, and they did a nerve and muscle biopsy that also grew cryptococcus. Optho came back, and they did intravitreal injections of ambisome. The vitreous actually never grew cryptococcus. Ortho took him to the OR and did washout of both knees. Unfortunately, that was complicated by wound dehiscence, and he had to go back to the OR. Regarding the cryptomeningitis, he required around 25 lumbar punctures to lower his intracranial pressure, ultimately did not get a shunt. This repeated lumbar punctures was complicated by iatrogenic bacterial meningitis requiring IV antibiotics. He was treated for disseminated crypto and cryptomeningitis with ambisome and flucytosine for 4 weeks after the first negative CSF culture. And then, like you discussed, which azole was picked? They ultimately picked voriconazole for treatment of blasto and the crypto. And then for the MAC, like I mentioned, it grew 3 times, so they treated it with azithromycin and ethambutol. Unfortunately, had a very difficult hospitalization. It was over 2 months in the ICU. He required tracheostomy and PEG tube and dialysis. His neurostatus remained poor. It was gradually improving, but he ultimately was discharged to an LTAC and unfortunately never really improved and was transitioned to comfort care and died about 3 months later.
Did this patient have a CD4 count?
I don't believe so.
So they don't have HIV, but there is an entity called idiopathic CD4 lymphopenia, and we don't know exactly how that happens. And so they effectively could have an AIDS-like syndrome without actually having HIV, because it just boggles the mind how he could pick up so many advanced OIs in just the 3 weeks of steroid exposure. So I wonder if he was immunocompromised even before that. And if this were still an active case, I would think I would look at the CD4 counts and also their anti-interferon gamma antibodies if he had acquired an anti-interferon gamma syndrome. Am I preempting more stuff from you?
No, that's it. There's just a couple of teaching points I had that I learned from this case. So specifically when we talk about cryptococcus meningitis, why do we care so much about the intracranial pressure? This is a critical determinant of outcomes for patients with cryptomeningitis, and the data behind this is extrapolated from patients living with HIV, but in those studies, there was an increased incidence of impaired mentation with patients who had higher opening pressures, especially greater than 35. So the recommendation is that if the opening pressure is greater than 25, drainage should be performed to target either a normal pressure of less than 20 centimeters, or if the opening pressure is markedly high, just a 50% reduction. And then I asked the question, in patients with identified cryptococcus infection outside of the CNS, when should you go looking for cryptomeningitis? And the answer is most cases, go looking. The information that I found indicated that, of course, if the patient has CNS symptoms or is immunocompromised, absolutely, you need to perform an LP and look for cryptomeningitis. If they're immunocompetent and have no neurological symptoms, but their CRAG titer is very high, go looking, perform an LP. And only in rare cases where they're immunocompetent, have no neurological symptoms, and their serum CRAG is very low, could you maybe consider deferring the lumbar puncture? And then, as we saw in this case, the treatment of disseminated cryptococcus and cryptomeningitis is complicated. So it goes through 3 phases: induction with amphotericin and flucytosine, as was seen in this case. The duration is at least 2 weeks, and the actual choice of duration is dependent on a number of factors, including the immune status of the patient, their clinical response, the presence or absence of neurological symptoms, and when you're repeating the lumbar puncture, when that CSF sort of sterilizes. Then you go through a consolidation phase with an azole, typically a higher dose azole for at least 8 weeks, and then maintenance for around a year with a lower dose azole. Any other comments, Dr. Cabrera, before we end the case?
Would also appreciate if everybody knew that the cryptococcal antigen stays positive for life. In an asymptomatic person doing well, same cryptococcal antigen, please don't page our on-call fellow at 1 a.m. It stays positive for life.
Great. Thank you, everybody. Thank you, Dr. Cabrera, for that awesome discussion.